Hello everyone and welcome to the 3D Systems eSimulation Interactive webinar. I appreciate you joining us today and I hope you will be able to join us for future webinars as well. My name is Shani Fargun and I'm a product manager in the ANGIO Mentor Simulator team. I will be the moderator for today's webinar. I am honored to present our guest proctor for today, Mira Konda-Paneni, an interventional cardiologist from Metro Health Cleveland. Mira, forwarding to you.
Thank you, Shani. Welcome, everyone. And as Shani is going to go through the module, I'll try and guide you through the basics of coronary anatomy. And if there are any questions, as Shani has recommended, you can post it on the Q&A and Shani will forward those questions to me and I should be able to answer you as much as possible real time. But we will be more than happy to answer at the end of the session as well. All right,
Okay.
Go ahead, Shani.
We can start with areocaudal view.
So areocaudal is a view that lays out the distal half of the left main as well as the bifurcation of the left main really well. I want to just go back a little bit and assuming you all have some idea about the views. When we say RAO, caudal, as you could see, the II is onto the patient's right side and towards the feet, which is the caudal. That's the position of our II. Coming back to the view, like I mentioned, the distal left main and the bifurcation of the left main are quite well visualized in this view, along with the proximal parts of the vessels, especially the proximal LAD and the proximal circumflex. The OM branches are also well visualized in this view, and they are laid out a nice crossing across. As you can see, they're traversing across the length of the heart in this view. Shani, we can move to the next one. The shallow RAO or AP, which means the camera is pretty much straight facing the spine with a good 30 to 40 degree cranial, meaning facing closer to the face. That's the view. That's the shallow RAO cranial view. And this view lays out your mid to distal LAD very nicely. As you may have seen, the difference between the two images that we have seen, the cranial views tend to show the mid to distal vessels laid out nicely, whereas the caudal views tend to show the proximal parts of the vessels nicely. And I would keep reminding this as we go through each picture. So in this view, you could see that the left main and the proximal parts of the LAD are somewhat foreshortened. They're not well laid out. But if you see the distal vessels, the mid to distal segments of the LAD is nicely laid out. There is some overlap in this view, which could be confusing, but otherwise, as you can see, the septals are coming to the left of your screen from the LAD, and the diagonals are coming at a more acute angle onto the right side of your screen. So that's about the coronary anatomy in this view. Shani, can you go back to that shallow RAO one more time? and pause it. One of the other things we haven't gone through is identifying LAO and RAO without really looking at that bottom left corner. So one of the ways to identify whether the image is an RAO or an LAO is to identify where the spine is. In the RAO view, your spine is towards, so this is a good RAO. The spine is towards all the way to the left of your screen. And now, Shani, move it to the LAO. And as the screen moves to the LAO, the spine is going towards the right of the screen. So that's one, using the spine location. Spine is usually the opposite side on the screen to the L or the R. And when it is AP, as you can see, the spine is right in the middle of the screen. So now, one of the other things to look at is the crani or the caudal positions. So now go to the crani position, Shani, like about 30. And you can see that the diaphragm is coming into the picture at the bottom of the screen. You can see the diaphragm moving with the respirations of the patient. And now come all the way to the caudal. And as you see, the caudal number is increasing in the bottom left corner. You see that the diaphragm disappeared. So another way of recognizing the caudal view is no diaphragm. Cranial view, you usually tend to see some amount of the diaphragm. So with that, let's go to the LAO cranial picture. So with the LAO, as you can see, if you can turn to 30, and yeah, what you have is pretty good. So with the LAO, you can see that the spine is going more towards the right of the screen than before. And now you can also see that the diaphragm at the bottom of the screen, which tells you that this is a cranial view. And this is very good to, again, lay out the LAD. So now let's inject. And as you can see, the LAD is coming straight down more towards the left of the screen. And the septals are coming on to the left of the screen. The diagonals are coming on to the right of the screen. And this is, yeah, as you can see that. Again, the very proximal vessels on the left main are foreshortened because this is a cranial view. And remember, I said the distal and mid portions of the vessels are well visualized in the cranial views, which is what we are seeing. We are going to the LAO caudal. Again, as you can see, let's go to about 40 of LAO and 30 of caudal. Yep, that's good. So you can see that the spine is angling. This is the position. The spine will be angling towards the right of the screen, whereas you do not see the diaphragm because this is a caudal view. And what you're seeing, the main focus is the circumflex in this view. Typically, you can see the left main nicely laid out, both proximal and distal left main along with the bifurcation. So this is a beautiful view for the ostia of the circumflex as well as the LAD. And if there is a ramus vessel, you see it right in between the LAD and the circumflex, which we are not seeing in the angio itself. But if you see onto the pictorial, you could see where the ramus would potentially come in. And you can also see the beginnings of the marginal and the origins of the marginal vessels from the circumflex well, but you may not see the very tips of the circumflex marginals in this view. This is primarily a left main, and the proximal LAD circumflex could be very well visualized. So now, those are the 4 basic views that we normally use to get the information. the ariocaudal, the shallow ariocranial, the LAO-cranial, and LAO-caudal. If you imagine this, it's actually moving in a clockwise direction, starting at the ariocaudal if you are in the real lab. Now, if you want more information, there are a couple of at least 2 to 3 additional views that you could do based on what you want to see. A left lateral view is typically used to see the mid LAD well, and especially where a lemur graft would touch down the mid LAD. So you go as far as you can. A lot of times, if you're doing a radial case, you may not be able to go all the way, but anywhere about close to 70. So this is how far the II has to travel. Almost 90 degrees from what we have been using before. And now, if you inject, the LAD would be coming onto the right side of your screen, sorry, onto the left side of your screen. And the circumflex would be going in the opposite direction. So if there is a graft that is hooked to the mid LAD, you can absolutely get a clear view of that distal anastomosis of the graft, and you can see if there is any lesions over there. So that's primarily the main purpose of this view. So an additional view for LAD that we tend to use if there is a lesion in the mid to distal segments and you want to lay it out better, the RAO, the shallow RAO cranial did not help you to do that, then you would go a far RAO cranial. So you'd go RAO about 30 and you go cranial about 30. And again, going back to our basics, you know this is RAO because this spine is onto the left of the screen and you're starting to see the diaphragm at the bottom. So that tells you, that confirms you that this is an RAO cranium. And now you can see the LAD hugging on to that outermost border of the heart onto your right side of the screen. And it's nicely laid out. So if you have any lesions that are hiding that you couldn't see before, this view can open up the mid to distal very well. Again, LAD on the top, circumflex towards the bottom. Again, the proximal vessels are not, this is not the view that's best for the proximal vessels because they're foreshortened, but anything from mid to distal vessels can very well be visualized in the cranial views. We'll move on to the next view. So this is an optional view for circumflex. So again, you have finished your 4 basic views. You have seen something in a circumflex or the marginal and you want to take an additional picture. This again lays out the distal left main, the bifurcation, and the proximal circumflex, proximal LAD, and the marginals very well. Pretty similar to what an ariocaudal would do, but the marginals are even better seen. And if there is a ramus, that can also be better visualized in this view rather than the ariocaudal. So for any ramus lesions or circ lesions, I usually recommend that you do this extra image. In this view, as you can see, this, given that this is AP, the spine is more or less to the center of the screen, and the vessel that is in focus is the circumflex, and the LAD is somewhat foreshortened on the top of the screen. And you can nicely see the left main with that bifurcation. So moving on to some right coronary views now. So we'll start with what we call the plain LAO. So let's get to LAO 30 to 40. That's beautiful. And as Shani was moving the screen, you saw that spine went towards the right of the screen. So we know this is an LAO, and we are not cranial or caudal. This is flat LAO. In this view, the right coronary artery looks like a C, hugging on to the atrioventricular groove on the right side. You can see the ostium and the proximal part of the right coronary artery very well laid out. You can see both posterolateral as well as PDA branches, but you don't see them opening up very well in this view because there will be some overlap. Anytime you want to see the distal bifurcations of any vessels, you go crani, the distal vessels open up much better. So Shani will now go to the LAO crani. So the same LAO, but she would go about 20 of the crani. And when we inject, now you can see that the bifurcation or the distal vessels are more opened up. As you can refer to the pictorial on to the left of the screen, you can see at the bifurcation, the top vessel of the bifurcation is the posterolateral branch coming from the RCA. That's good. Now show the PLV, Shani, on after the bifurcation. And the bottom vessel after the bifurcation is the PDA. Yeah, that's the PDA. And that's the view. Again, we do not have the labeling for the right coronary artery, but then go to 30 of the LAO and 20 of the crani. That's good. Inject. And you see the distal vessels nicely opened up with less of an overlap. So that's the advantage of going crani. Anytime you want to see the distal vessels open up nicely, you go cranial, and that gives you a better clarification. Now, what if we need to see more of the mid RCA? You go to a plain RAO. So go to about 35 to 40 of the RAO. And as we are coming to the plain RAO, you can see that the spine has moved to the left of your screen now. And the previously looking, the C-like RCA is now coming straight at you. So the C, the body of the C is towards you. So you're not seeing the C. And that's middle part of the C is now the mid RCA, which is very nicely laid out. So there is any concern for any lesion in the mid RCA, your angiography is never complete without a straight RAO view, which lays it out nicely. And this picture is also helpful for two other features. As you can see, the spine is to the left side. To the right side of the screen is your anterior part of the heart. And what lays in the anterior part of the heart? Right ventricle. So the marginal branches that you can see that are coming off the mid RCA are going towards the right of the screen. So that's a nice way to differentiate the marginal branches right in the middle of the heart. And the PDA in this view usually comes at the bottom, and you can see that the vessel is hugging the very inferior wall of the heart because the PDA runs in the posterior descending interventricular septum, and it's usually laid out nicely. In this picture, the PDA seems to be a relatively shorter vessel, so you don't see it going all the way to the apex. But if you have a long PDA, you will see that right hugging that bottom part of the heart. So again, a view to remember from mid-RCA to clearly lay out the marginal branches which are going to the front of the heart, and as well as to lay out a PDA that could be long. You can see it nicely layering at the bottom of the heart. So this completes our right coronary artery views. So what we have seen are all the general views that we do for the LAD, circumflex, and the right coronary artery. Again, to remember, cranial views lay out LAD better, distal vessels better. Caudal views lay out the circumflex better, and the proximal vessels better for the left coronary. Shani, back to you.
Maybe we can talk about the methodology a little bit. Clockwise pattern for the left side.
Yep. Can you move the eye as I can stay in that the patient mode?
Okay.
Yeah, that's perfect. So now,
Yeah.
okay. So if you start at the RA caudal, are you gonna show them?
I have to close it.
Oh, I see. Okay, that's fine. So what you have now on the screen is the RA caudal.
Yeah.
Okay, we can start there. Okay. So if you're looking at our screens while you practice, look into the left side of the screen where we have the II locations laid out for you. So when we start with the RA caudal, you can see the II is on to the right of the patient and towards the feet. From there, we tend to go to shallow cranial. You can go. So the II has moved up towards the patient's head, a little bit more to the middle of the screen.
Okay.
And then as we continue to move the clockwise, the next in the clockwise rotation would be cranial. Now, the II has just moved from a little bit to the right of the patient to now left of the patient. We are still at the head of the patient. And then the last basic view would be the monitor stays in the LAO view, but we just come all the way down to the caudal. So that completes that circle. So we started on the right bottom of the patient. We went to the head end of the, there you go. We went to the head end of the patient for RAO cranial, and then LAO cranial, and finally to the LAO caudal. So if you practice, you can see that this is a nice clockwise way of moving the II. So right there, good. Go to the top, go to the RAO cranial. Shani, you're doing well. Yep, right on this screen. So stay right there. That's good. So that's RAO cranial right now. There you go. And move to the LAO cranial. The other way. There you go. That's the LAO cranial, our third left coronary image. And now just come, stay the LAO and come to the caudal. Exactly. So that's the way the II moves around the patient in a clockwise direction to get the 4 basic views for the left coronary system.
Okay.
And for the right coronary, we kind of start at the LAO straight. Good. And then we go to the LAO crani. And that opens up the bifurcation as we talked about. Now we come all the way down to the RAO straight. That's the RAO straight to complete the right coronary images.
Okay. Okay, thank you, Mira, so much. We will wait 3 minutes in order for people to be able to ask some questions. Let's see if we can have some public questions in here. This is something that you will not see in the simulation that you have, but in the ANGIO Mentor, in the simulator, you can also get a feedback report telling you how well you did, meaning how many views you got in the first try, and how many you didn't get, and you get a final grade. Let's close that. Okay. All right. I know that the attendees are in a slight delay, so we will wait a few more minutes in order for them to ask questions. In the meantime, Mira, I know a lot of people are curious about the coronavirus situation in the hospitals, and I know by talking to you that we had a few procedures that were traditionally done in the cath lab, but now were moved to the bedside. Um, can you tell us a little bit about that as well in relation to the coronary views that we just discussed? You are on mute also. Maybe you can unmute.
Oh,
Yeah,
yes. Sorry.
thank you.
In, and as much as we wish, the coronary angiography can still not be done at bedside. So the left heart caths have to come down to the cath lab, and we are obviously preparing, how to deal with it about a COVID patient coming down to the cath lab. So we have a whole big protocol of the precautions we need to take if they're traveling, and how to clean the room once we do a coronary angiography patient who has COVID. But the procedures that we tend to do now more at the bedside, previously we used to do maybe a few right heart caths in the CICU at the bedside, especially in patients who did not have pacemakers or defibrillators. It's kind of, of our first line if they're in the ICU and we can transduce, then we used to do the right heart cath at the bedside. What has changed now is pretty much all highly suspected patients who may have COVID or patients who already have been diagnosed as COVID. We are doing all right heart caths, especially if the patient has hemodynamic instability and there is concern for cardiogenic shock. We are doing right heart caths at bedside, irrespective of whether they have a pacemaker or not, and being careful. Whether we can either use a C arm or we are doing an X-ray before X-ray afterwards, or especially if we adjust the position of the Swan-Ganz catheter. So, because we have done them before quite a few times at the bedside, I do not think this is a big change in the practice for us. But what I would say can potentially be a little bit more challenging in terms of the learning is the balloon pumps. They raise a little bit of a more affinity towards putting balloon pumps because they could be put at the bedside, compared to the impellers, which need the patient to come down to the cath lab, because you need more of a visualization and more trained personnel as well to be available. But with the balloon pump, if the patient is in shock and they want us to place a balloon pump for that cardiogenic shock purpose, we are now trying to do them at bedside. Previously, everybody used to come down to the cath lab. Now we are doing them at the bedside with the help of either a C-arm fluoroscopy or just plain X-ray. We measure the balloon pump from the patient's manubrium or the sternal angle to the groin, and we kind of have an idea how much length do we have to introduce the balloon pump to, and we place it. We see if we get good augmentation of pressures on the console. We get an X-ray if you don't have a C-arm, and then we look at the X-ray, and if we need to advance or pull back, we do that and repeat another X-ray. So that is definitely a change in practice if it comes to the balloon pumps.
Okay, that was super helpful, and I'm sure many hospitals are doing the same. I have a question regarding the training. So now I'm guessing there are not many live cases. So
Mm.
do you use simulation or some other kind of training methods in order to train your residents and fellows?
Absolutely. Most of our training has now changed to web-based. We moved most of our conferences to web-based. So definitely, we are with the beginning of this season, like, of the COVID season, like last 1 month or so. But as we go further into this, the volumes, if they remain low, it certainly is going to affect the training skills. I'm particularly worried for the first years or the new fellows that are going to come in. And I think having webinars like this, or the web-based teaching apps for coronary angiography, for view identification, irrespective of the COVID season for that matter, it's a great way to learn the basics without subjecting the patient to receive higher radiations, because a lot of times this kind of prolongs the procedure, or the radiation time sometimes, as we are trying to teach the residents, or the fellows, how to get a hang of these views and images. So I really think, thanks to the COVID times, we are doing more and more of this training by simulations, which I think will carry forward even when things get normalized. I think this is one of those blessings in disguise kind of thing, that we are all learning to use more simulation-based training for our trainees.
Okay, I definitely agree with you regarding these methods that we are creatively developing as we go through this time of the coronavirus. I would like to thank you so much for joining us to this session right now. And for our live viewers, we will send a recording of this webinar to your emails as well. So thank you so much, Mira, for joining us for today's webinar. It was a
Thank you.
pleasure.
Thank you, Shani, and thanks everyone who have participated. Bye-bye.
Okay, bye. Thank you. We will end the session now.